Thanks again to everybody for being at this Institute on Aging presentation called Partnering with Patients to Elevate KPSF's Geriatric Emergency Department. I'm going to turn it over to the team right now. They're going to speak, and you can see their names there. We have Marlena Tang, MD, Olivia Tan, consultant, and Ryan Wilbur, who's TPMG Senior Consultant. I'm going to unpin myself, let you see them and hear them, and we will take your questions and pose them at the end.
Great. Thank you, Catlin. First off, I really want to thank you as well as the Institute on Aging for not just today, but your continued support as we've worked towards implementing our GED. Really excited today to speak to everyone about an important aspect of the GED work, which is bringing the community into this process to make sure that we have input from the community and it truly reflects the needs of the people that the GED is meant to care for, as well as the family members and caregivers who help support the types of patients the GED is designed for. So today we have a few different topics that we're going to touch upon. First, we'll briefly cover what a GED is, as well as why GEDs are important. And then we'll get to the crux of today's session, which is talking about the Patient Advisory Council, which is something that Kaiser Permanente employs quite frequently across service lines and care areas to help us achieve our goal of delivering patient-centered care. So we'll talk about the Patient Advisory Council specific to the Geriatric Emergency Department, the people who are eligible to serve, as well as more generally about the types of impact that the Advisory Council can have, including some examples of existing patient advisory councils and the types of projects and work that they have done to help us improve the care that we deliver. So with that, I'm going to turn it over to Marlena Tang, who is going to be the medical director of our GED upon implementation.
Thanks, Ryan. My only disclosure for this talk is that someday I too will be an older adult and I'm probably going to use GED services. So I'm designing it with myself and everybody on this call in mind. I want to talk a little bit about what GED or Geriatric Emergency Department is. A GED is not a fancy physical space. It's actually a culture of care, and it's changing the culture of care in our ER. We want to tailor it to the specific needs of our older adults. Our focus is on improving clinical outcomes and reducing unnecessarily. We basically want to reduce harm is the main thing. And key components of an effective GED you'll see are fivefold. We want to increase geriatric-focused education for our staff. We want to increase the types of people who are staffing our GED. So traditionally it's the ER docs and nurses, but we realize that with our geriatric patients, that an interdisciplinary team, much like hospice, is most effective and important in addressing what matters most to our older adults. So getting social work, PT, pharmacy involved in the ED where traditionally they haven't been. This is something that we are going to be doing. And we're looking for feedback because it's going to be our first time really involving more team members in the ED. We're creating policies and standardized approaches to common geriatric issues, such as geriatric fall syndromes for the first time. We are trying to do quality improvements and enhancements of our physical environment with chairs in addition to our gurneys, some no-slip bed rails, light dimming and hush curtains so that people can hear, and providing assistive devices for both seeing and hearing. And one of the things that's near and dear to my heart as well is optimizing the transitions of care. Once you're done in the ED and you're admitted either upstairs or you go home or to maybe a new place of living, that's a big change. And we want to help optimize those transitions for our most vulnerable adults and make sure that all of the biopsychosocial drivers are being addressed. Next slide, please. So it sounds like a lot. I'm going to just talk a little bit about the ED for an older adult and what usually happens. Let me just go ahead here. So let's take this case of Jane. This is the current state of most EDs in the United States. Jane lives alone. She's 82 years old, and she's a widow. One day, Jane falls when she's gardening, and she gets an abrasion on her right ankle. Over the next several days, Jane's ankle becomes more red and swollen, and it's painful. And then she's thinking, maybe I should get it looked at. Her PCP is not available, and so she goes to the ER. She goes to a typical ER in America or San Francisco before our GED initiative. She sees me. I diagnose her with cellulitis, and I discharge her on Bactrim and Keflex. You know, very typical care. Unfortunately, over the next week, she becomes weaker. She has another fall. She returns to the ER, but now she's found to have kidney failure. Her potassium is high, and because she comes on Friday night in San Francisco, there's no beds in my ED, so she is one of our, hemodynamically stable patients. She gets put in a hallway gurney. Does this sound familiar to everybody? Yeah, she gets put in a hallway gurney. A Foley catheter is placed because she's not able to ambulate to the bathroom, and she's admitted. Her hospitalization gets prolonged. What becomes a cellulitis becomes now renal failure and delirium. She gets a UTI from her Foley. She stays in the hospital in excess of 5 days over what she could have stayed with cellulitis, and she's discharged to a SNF because of profound deconditioning during her hospital stay. So now it's not clear whether she'll be able, if she'll ever be even able to go home or garden again. So what does a geriatric ED do? What if we could identify in our ED and appropriately treat those older adults like Jane who are at higher risk of bad outcomes? In an ER, we're very task focused. You have a burn, we take care of your burn. You have a heart attack, we take care of your heart attack. But with some of our older adults, we need to change the way we think about our patients. What if during Jane's first ER visit, she went to a geriatric ED and she had supports such as a geriatric pharmacist who would have stopped me and said, Dr. Tang, Bactrim and Keflex are great for her infection, but not so great for her because she's on an NSAID and she's on another chronic medication, an ACE inhibitor that might interfere with this and she might hurt her kidney. What if she had a geriatric care coordinator, who could help her with her care transition home? And in that first week, actually make sure that she's, not going to be falling, that she has enough food, that she's taking her medications appropriately. What if staff and physicians were better prepared on her first visit to address what matters most to Jane, which is being strong enough to garden and tailoring her plan of care towards that? All these interventions, could they have staved off her decline? It's the question we want to answer with our geriatric ED. Let's take a look at Jane's second visit. If she went to a GED during her second visit, during that visit, she still would need to be admitted for the fall and the worsening cellulitis. But we would recognize delirium in the geriatric ED with our cognitive screening and delirium screening. We could educate our staff to avoid iatrogenic complications, such as a catheter-associated urinary tract infection. We could identify the key psychosocial issues that Jane is driving Jane to the ED. Living alone, maybe being at risk for falling in her home. We could allow for virtual family visits by leveraging some video technology that we started using during COVID, and we've been using with our older adults who have family members living outside of San Francisco, and getting everybody kind of on board from the get-go in the ED rather than on discharge. And then lastly, we could optimize our ED physical environment to be the least deliriogenic for Jane. Instead of being in the hallway, a quiet, respectful space with dimming lights and access to food, water, and mobility. Doing these things in the ED, although they seem common sense, they actually would shorten, through research, her hospital stay from 7 days to something like 2 days. They would avoid the deconditioning that she had had. They would reduce the delirium and allow her to go home, which is what matters to her, instead of going to a SNF, and to regain her independence. So the data does show that GEDs, next slide. The data does show that GEDs can reduce future ED visits and reduce inpatient admissions. They have positive impact for the hospitals, they have positive impact for the patients, and they have positive impact for the staff who feel we actually have some tools now that we can help our patients with what they need. And we at Kaiser believe that our GED that we're designing, that our impact will be most amplified when we listen to our patients and their caregivers, and we design a GED process that involves feedback from our patients and caregivers. We have been reaching out to some of our local advisory groups, and that's what we're here to talk to you about today. We're learning so much from the patient voice, just little things that change our culture, like things that we took for granted that we're trying to change, not calling diapers diapers, to calling them adult undergarments to the patients, maintaining some dignity during the visit, trying to address people by their names, and making sure that we don't inadvertently to go to honey or sweetie off the bat. We're just starting to learn from the voices that we've talked to already. And we are really excited about changing our culture and improving our care for our older adults. So next slide, please.
Great. Thank you, Marlena. So now I'm going to take a little bit of time to talk about the GED Patient Advisory Council, its makeup, and the types of individuals we hope to recruit to join us in improving geriatric care at KP San Francisco. So as envisioned, we're looking to recruit between 8 and 12 individuals to serve 1-year terms. They're renewable. So ideally they will be patients, family members, or caregivers. And the obligations are essentially, we're going to meet quarterly for 2-hour meetings. We hope that people will be able to join that. Our patient advisory charter sets a minimum threshold of 75% attendance. Beyond that, especially in the early days when we're designing and implementing, we hope that our advisory council members will join us for additional meetings and performance improvement opportunities, including coming to the ED and walking the floor and seeing how things will work so that they can really be in the moment and share with us, yes, this is what we need, or actually, that would not be good, so that we can really learn from them and have them deeply involved. In terms of standard obligations, though, we expect or hope that Patient Advisory Council will be member driven. So for them to define and drive each quarterly meetings agenda, they will have support from KP staff. At least one person from the GED staff, as well as potentially from Olivia's team, will join each meeting to act as a conduit between what the advisory council identifies and works on to KP staff to make sure that their work really does have impact. In terms of things that they'll be able to do, they'll be able to highlight areas of concern, opportunities to improve, and if they really want to take ownership, we've had other advisory councils that have set up and executed their own improvement initiatives. So the possibilities really are pretty wide and dependent on how much members want to do. And then on the right, just a little bit about Kaiser's approach to care and how these patient advisory councils fit into that. So Kaiser, for I don't know how long, years, has embraced patient and family-centered care as a principle for driving how we model, design, and deliver our care. So for those of you who don't know, it's an approach, it's a philosophy that is centered around the idea that partnering with stakeholders beyond paid staff, insurers, can really help us to elevate the type of care that we deliver. And more tangibly, patient and family-centered care approach helps to shape policies, programs, even facility design, and the way that staff interact with patients on a day-to-day basis. As members of the GED Patient Advisory Council, they'll have the opportunity to work on all of these things, especially given that the GED doesn't exist yet. So it's really an opportunity to not go in and say, oh, this is wrong, we need to fix it. It's an opportunity to make sure we get it right from the start. So then the question you hopefully are eagerly waiting the answer for is what makes an ideal candidate. So generally speaking, there's two categories of individuals we're looking for: patients and then their family members or caregivers. So for patients age 65 years and older, a KP member who receives care in San Francisco. So that could mean they live in San Francisco. It could mean that they work in San Francisco and potentially could be using the emergency department. But at this point, we are trying to recruit specifically members of Kaiser Permanente. We also want to be clear that having dementia or cognitive impairment does not necessarily bar someone from participating. In fact, we would really welcome individuals with early stage dementia or cognitive impairment to participate because the GED, one of the core groups of people we really built this to help are people with cognitive impairment and dementia. So it would be great to have that firsthand perspective. On the family and caregiver side, they do not themselves need to be a KP member, but so long as they are supporting or have supported someone who was a KP member or someone of any age who has cognitive impairment. Right now, we are looking to recruit non-professional caregivers. But depending on how recruitment goes, that may change in the future. But for now, looking for non-professional caregivers and family members who are supporting older adults. So, and then a few things that apply to everyone. So just having a commitment to improving care generally, which I imagine no one would volunteer if they didn't, as well as being able to do so in a respective, productive way. A real goal of this council is to recruit membership that is as diverse as the city is going to serve. So being respectful of all individuals and their own views and perspectives and where they're coming from is a prerequisite. And then beyond that, being able to join us for a minimum of the quarterly meetings each year. Have previously had some questions about whether there is any compensation related to this. It is a volunteer position, so it is unpaid at this point. However, I've been able to confirm that we will be able to reimburse anyone for parking, as well as provide complimentary transportation for those who don't have cars or can't drive via our partnership with Lyft. And I think that is everything. I'm now going to turn it over to Olivia, who is going to talk about some examples of ways that councils have had impact at KP already.
Thank you for that, Ryan. I think you did an awesome job kind of highlighting what PFCC really does. Within Kaiser Permanente, we really try to be able to capture the customers' voices. But I'll go ahead and share more around what some of our PFCC councils have done. Here at San Francisco Kaiser Permanente, we currently have 8 active councils focusing on varying needs such as language, specialty care, and age-specific groups like this one, and also our Teen Advisory Council. Within Kaiser, there's been multiple improvement efforts to launch improvement ideas. Just to give you guys some examples, our oncology will be working on improvement call routing for their services. Pediatric Advisory Councils has developed a repository for online handouts. And our Filipino focus group has identified a gap in health education and resources for our Tagalog-speaking patients. So they're actually working on developing more documents and also a Filipino cooking class for them. Depending on your advisory council, the members, depending on the advisory council, the members and the participants are able to work directly on projects with our physicians and also the leads. Sometimes myself will also participate. I think a really good example of an improvement project is actually with our OBGYN. We also call them our MAC, our Member Advisory Council. They've been working on implementing a new breastfeeding and lactation workshop. The workshop was revised to bulk up the content and really kind of restructure when material was presented to new moms to be more effective. With the GED Council, you'll be working with Ryan, Marlena, and myself to identify improvement opportunities and provide valuable feedback to improve the care provided to our geriatric ED patients. Next slide. And so we really want to thank you for your time. And if this is the right opportunity and it sounds like something you might be interested in, or even your colleague might be interested in, definitely reach out and we'll have more discussion if needed. If you have questions, feel free to reach out. And I think there is a Q&A after this that will be led by Caitlin. So thank you, everybody.
Well, thank you. And that was a lot of information to digest. But the good news is we have a recording and we'll be sharing it here, as well as putting it on our IOA YouTube channel. So there are a few questions, and the first question that I'm going to pose is this program limited to the San Francisco Bay Area at this time? I guess I would follow that up with, is this a prototype being developed here in San Francisco, or are there other programs around the Kaiser service area that have already been rolled out?
So as far as I know, right now, we are the only GED Patient Advisory Council in KP Northern California. Redwood City actually beat us to the punch, and they already have implemented a geriatric emergency department, but I don't believe they have an advisory council at this time. Over the next few years, though, that could change. So the GED in San Francisco is the result of a grant opportunity that we've been working on for close to 2 years now. And the plan is to use this grant opportunity to implement in San Francisco, sort of prove the concept of a GED, that it benefits the patient, that it benefits Kaiser, and then use that as a model to spread throughout Northern California to each of our 21 emergency departments. So in the coming years, it is very possible and probably likely that there will be patient advisory councils for many, if not all, of our Northern California emergency departments.
And Ryan, I just wanted to add as well that in San Francisco, we've been partnering closely with UCSF and Zuckerberg, who are also opening up geriatric emergency departments, all with their own different flavor. You know, the UC hospital, the county. The county hospital is actually also trying to recruit some advisory council members. If you have anybody who's closely involved with the county system, you can send them our way and we'll refer them to the proper people at county. In terms of geriatric emergency departments nationwide, we're really at the forefront. This is a movement that's just starting in emergency medicine. This is not something you're going to see in almost any emergency department. And we are trying to be national leaders in sort of the way we rethink our care for our older adults. And we really do think the patient and caregiver voice is just as important as all the things we're dreaming up clinically. And so I do encourage you, if you know people in San Francisco who want to be involved in any way, even if they're not sure, we'd love to hear from them.
You know, you mentioned early stage patients participating, having worked with early stage patients and their caregivers. Would that be a duo that you would welcome, a caregiver and loved one, for example?
I defer to Marlena, but I think absolutely.
100%.
Yeah, I was going to say our own IOA Companion program, our Presidio program for people who, you know, many of whom are cognitively impaired, they will welcome this information, I'm sure, for a host of reasons. And we will be presenting this recording to the group that meets there. There is an ongoing support group that meets there so that they may take a look at this too. And we have a couple of other support groups that we're connected to. And let me see another question here. Oh, what is the capacity or anticipated capacity of the Kaiser GED?
So we are, we're taking an approach where, so the Kaiser San Francisco emergency department is quite small and insufficient for our current volumes. So rather than creating a handful of beds out of those 24, I think, beds, that are GED specific with dedicated staff who are sort of siloed off and only work those beds. We've taken the approach of training, educating, and upskilling 100% of our ED staff, as well as making environmental improvements to all of our spaces so that every bed and every space and every doctor and nurse and technician is able to deliver the elevated care that the GED model provides.
Okay. Oh, here's another question. I am a caregiver who sees my mother's friends all in their late 90s. This person lives in Orange County, California, and sees how many people need this kind of benefit. Perhaps a piggyback question onto that is, once this model is rolled out, is this something that's going to be picked up then throughout the Kaiser system?
We can't, none of us on this call can say for sure. That's certainly above our pay grades, but I know that in Southern California, 2 of our Kaiser emergency departments in San Diego have already implemented GEDs. San Diego County actually passed a measure mandating that, I forget by the date, but very shortly, that all county emergency departments have GEDs. Similarly, the California Master Health Plan is also encouraging all EDs to adopt GED principles and models. So I think that, you know, whether it's KP or outside the KP system, you're going to see them become more and more common. The accreditation was only created in 2018. In the first year, there were just a handful of EDs nationwide that became accredited, and now I think we're approaching 200 across the country. So I think that you will see it become more prominent everywhere. But as to exactly when and if Kaiser as a national system will adopt, I'm afraid we can't speculate.
Okay. I had a question based on Olivia's information, but any of you may answer. In terms of these advisory councils, of the ones that you showed on that slide, Olivia, or anybody, what is the oldest advisory council and what have their successes been that you can cite?
So I think the oldest advisory council is actually our language one, Chinese AFM, so Chinese Adult Family Medicine Advisory Council. They've been together, I want to say, for about 6 years now. And one of their successes is really building that physician membership relationship. And so for them, a lot of the feedback that I get from them is actually it's less of a meeting for them. Now it's more of like a social, their family, they can share a lot of, you know, their experiences with their providers directly. They have this direct connection with their physician. And I think that's probably the biggest success story, is that on both ends for the members and also the physician, it's definitely worked out in a positive manner for improving communication.
Anybody else have any thoughts or information about that? Or
I just wanted to say it's really important to have representatives from our communities that don't speak English as their primary language, you know, on our advisory council, because I think there's a lot that we're missing when we don't have someone who is a member of that community and can bring it back, can kind of walk between that community and what they see with our GED and what we think we're doing with our GED. It's really nice to have someone who can bridge both communities.
Yeah, and to build on that, specific to the GED, as a precursor to the advisory council, we actually held a focus group of patients and caregivers back in December. And just that one session really helped us to identify a number of things where we could improve and tangibly change the grant submission, the proposal that we ultimately submitted. Marlena mentioned a few of them earlier. A lot of it was centered around the dignity and respect of the experience we provide to older adults. But there were a number of things around frustration, a lot of examples of what not to do, which were very helpful. Yeah, ultimately re-centered our proposal on the patient in a way that was really helpful.
I think that speaks to one of the comments or questions that somebody had here, and it's are older people triaged in the uneducated ERs, as he put it?
I think that everybody is triaged based on severity in every ER across America. I think you can think of it like this way. A patient I saw last week, I saw a lovely 79-year-old woman who burned her hand. Very minor burn, just needed a dressing. She burned her hand while she was cooking dinner. So that's a very quick ED visit. Treat the burn, check the tetanus, send her home. But in an older adult, I think that you need to go a little further. You know, what were you doing when you burned your hand? What were you cooking? You know, cognitively, how's everything going? Are you able to take care of yourself? Are you at risk for falls? Did you fall into the stove? There's just additional questions and care that maybe we should have been doing all along. One could argue that we haven't been focusing on as emergency medicine providers, because we're just trying to sort of treat the emergency and then see the next emergency and then see the next emergency. And we're missing a lot of opportunity with our older adults to really intervene and, you know, bring attention to what's going on in their lives, you know, for their follow-up visit. So
I think that also, you know, that piggybacks onto another question, you know, what about listening skills for those who need healing of some sort? I think you just cited a perfect example. As one digs deeper, you might find out, you know, that there's some cognitive challenges or maybe, you know, possibly elder abuse. There are all kinds of things that can be uncovered in such a scenario. Does anybody want to speak further about listening skills and language capacity? How will you realistically serve language capacity if you have different representatives from some of the communities you'd like to woo into this project?
Well, the good news is that we have an extremely diverse staff at the San Francisco Emergency Department. I forget the exact number, but we actually put it into the grant proposal, and the number of languages spoken by our staff, I believe, was over a dozen. So I think typically there's someone in the ED capable of communicating, and when there isn't, we do have translation services. But as to digging deeper, I'll maybe pass that back to Marlena.
and just to clarify, language on the advisory council as an advisory council member or as a patient? Just wanted to clarify.
As a patient advisory council member.
In that case, we do need them to be bilingual, with one of those languages being English. We do have translation services, but I think for the functioning of the council, if we had, you know, say 6 different languages, that would everything having to be translated across multiple languages, it may impact productivity. So some degree of English competence, I think at this point we are asking for.
Thank you for clarifying that. Okay. Another question, what about outside the Permanente system? You're speaking to Kaiser, but are there other kinds of patient advisory groups that you know of that are also good models? And you don't have to be specific, but maybe that you've drawn from.
Well, Marlena mentioned that we know that San Francisco General is creating a patient advisory council as well. It's also a requirement. So to establish a GED, there's an accreditation program that has 3 levels of accreditation. And for the top 2 levels, so they're bronze, silver, and gold. For gold and silver, having either a patient advisor or a patient advisory council is a requirement of accreditation. So as GEDs spread, you will inevitably see more advisory councils. But at this point, I think we're only aware of SF General. There is a Sutter hospital within the city that is accredited, but I do not know if they have a council or not.
Okay. I'm looking for any other questions from our participants, but I'd like to throw a question out to each of you. And you've already answered quite a few questions about the program, but what excites you the most about this program in general, other than those points that you've covered?
Does anyone want to go first? I can.
I would love to
I-
take a stab. Oh,
Go for it,
sorry.
Marlene.
Oh, no, go for it, Marlena.
For me, I've been an ED doc for 20 years. I trained in a trauma center in LA, guns, everything. I have really wanted to improve the way we care for our older adults in the ED for a long, long time. And I think that we finally have some impetus thanks to the Dolby grant and also thanks to the national movement towards rethinking geriatric care in the emergency department to really make an impact in our older adults' lives. I think it's high time that the rest of the world realizes that the ED and that we realize that the ED is actually part of the continuum of care. It's not just a one-stop, emergency trauma shop. We are actually part of the continuum of care for our most vulnerable adults. We're like a safety net for the clinics and those who are unhoused and unhomed and don't have family. And I think that what we see and what we do matters. And I'm really, really excited that we can start this conversation with our community-based organizations, but also our upstream and downstream clinic and home care providers, just so that we can all try and talk together and communicate about how we can help our patients. So that's what I'm excited about.
Go ahead, Olivia.
Thank you. I think for me, what I'm most excited about, my background is in performance improvement, and this is the best way to really get down closest to the work by getting closest to the people that are affected. So one phrase that always comes to mind is nothing about us without us. And so really being able to work directly with our members to identify improvement opportunities is what, my background comes in to really improve the care that they get. So yeah, again, my interest is really around PI work, and being able to be a part of this is awesome.
Yeah, building on that also as a consultant, I've spent more than 10 years now trying to solve different problems in healthcare. Sometimes it's access, sometimes it's capacity, sometimes it's patient experience. Sometimes it's a benefit for the patient, sometimes it's a benefit for the provider. This is the rare situation where it's a win-win-win-win-win for everyone involved on, whichever way you measure it, it's a win for everybody. And that's just really exciting and, rewarding for me.
What I love is the enthusiasm here. I mean, watching this as a parent or a caregiver, what I'm hearing, if I were to be involved in such a patient advisory council, I would feel very inspired by your words. And that phrase, nothing about us without us, really speaks to the full patient experience. So that is wonderful. We will certainly, as I said, be posting this on our Institute on Aging channel, and we'll be directly sharing this with many of our other aging services colleagues here in the city, so they can share it with their groups and other colleagues as well. I'm looking in the chat and the Q&A, and I don't see any other questions at this time. So I'm going to say, if there are no other inquiries about the program on the part of our attendees, we will say thank you very much for being with us today. And the information about continuing education for those who are present is in the chat, and I'll be getting in touch with all of you. Again, Ryan, Marlena, Olivia, on behalf of Institute on Aging, thank you so much for being here with us today.
Yeah, likewise. Thank you for your time, as well as everyone else who's attended.
Thank you, everybody.
Thank you.